Oh, what happened here? Okay. So thanks, Kelly, for a wonderful talk and for making my job quite a bit easier by explaining what systemic therapy is. So we might even be able to catch up some time. So I'm Harriet Kluger. I'm one of the melanoma oncologists, and I'm going to be talking to you about treatment options for advanced disease. So specifically disease that's not resectable in those places like the lung, the liver, the brain, all of the internal organs that we don't really want Kelly going to, although sometimes she can and does. So you saw the slide earlier, Sarah Weiss showed it, essentially showing that although melanoma most of the time presents in early stages, so just on the skin, when it does metastasize, that's when you need us in the picture. I took this slide from a journal that was published in 2004. It's a summary of all the studies that had been done to that point on what we call systemic therapy, which means therapy that we take either by mouth or by IV, so it goes to all the different cells in the body. So I know you can't see the fine print then, but the summary is it was negative study after negative study after negative study. So although many of us were diehards and really tried persistently, we weren't successful at all until maybe the last 10, 15 years. So since 2011, we've got a list there of drugs that have been approved. All of these were approved because they improve survival in patients whose melanoma is no longer resectable. At the top, I have the list of the drugs that target the melanoma cells, those that have that mutation that was mentioned. Those drugs are only useful in about half of the melanoma patients. And at the bottom, I've got the list of the immune therapy regimens that are now approved by the FDA and are used in treating this disease. So we're going to spend the next few minutes talking about some of those. So immune therapy is not a completely new concept. In fact, there was a surgeon in 1891 who came up with a toxin that was made up of a bunch of dead bugs, and he tried to treat sarcoma patients with it. The results were somewhat ambiguous. Unfortunately, we've made some progress since then, but that's, I think, where the idea first started. So I think Dr. Lino actually mentioned this a little bit earlier, that if you take patients whose melanoma has spread and you resect some of those, or you give patients old-fashioned chemotherapy or old-fashioned immune therapies, we always really had what we call a tail at the end of the curve. There was always a small percentage of patients that survived even before we had the new treatments. So this one over here is surgery alone. As you can see, 10% or so of patients whose disease has spread beyond the original site will do fine just with surgery. Chemotherapy did a little bit of good here as well, as did some of the other older therapies, but it's nothing like what we see today. This is a timeline that I borrowed from a colleague of mine showing what the survival was in patients over time. And if I just click on all the buttons, you can see that as we progress towards 2017, we're starting to see a huge percentage of our patients, over half, doing very well on these new therapies. Now, do we know if everyone is cured? The answer is we still don't know. Even patients who've been off therapy for over 10 years, and I think there's at least one of those people sitting here in this room, we think they might be cured, but it's a little hard to tell. And we'll have more information over the next 10, 20 years. So the very first of the newer drugs that was approved is this drug called ipilimumab, or Yervoy. This was the result of the study that led to its approval by the FDA. And what you can see is that around 20% of the patients did well on this drug. 20% is better than 10%, but still not nearly good enough. This is a patient of Dr. Schnoll's who was treated in 2007. These are his lungs, and you can see all these little white spots there. Those are tumors, and in fact, he had them in the brain as well. After a few doses, the brain cleared up, the lungs subsequently cleared up, and I just checked with Dr. Schnoll. He is still alive, well, and off therapy. So that's pretty amazing. So there's another person in this room also who was on this very same trial and still doing well and also disease-free and just comes to see us every few months to visit and say hello. So I'm just going to say there that participation in clinical trials doesn't mean that there's no hope. In fact, this oftentimes is the vehicle for hope. So this is just a little cartoon that I again borrowed from Dr. Schnoll, also well over 10 years ago. And it basically describes how some of these immune therapies work. So we make cancer cells. And how does our immune system get rid of them? Well, they recognize them as foreign because the cancer cell will present certain abnormal proteins to the immune cell, and that starts a whole bunch of crosstalk mechanisms between the two cells. So some of these are positive signals to make the immune cells stimulated, and some of them are negative signals to make the immune cells slow down and sometimes even die away. So many of these, we call them checkpoints. Many of these checkpoints or crosstalk mechanisms between the two cells have now been characterized. The first one was the CTLA-4. That's the one that's drugged by the ipilimumab. So CTLA-4 comes to the surface of the immune cell once it's been stimulated, and it basically turns it off. So if you take a drug that blocks CTLA-4, you're putting a brake on the immune system. The other one is PD-1 that Dr. Lino mentioned. It's targeted right now by two drugs that are approved for melanoma, nivolumab and pembrolizumab, also known as Opdivo and Keytruda. And these are two very different checkpoints within the immune cells. So this is a more modern and contemporary cartoon, and as you can see, there are many more molecules over here. And this one also needs updating. And essentially, I put circles around all of those that are targets of drugs that are currently in development. So this is a burgeoning field. Over here, I have a slide that was shown by Dr. Schnoll in 2010 at ASCO. It essentially was the very first trial of patients who received this drug Opdivo or nivolumab for metastatic melanoma. And this table over here represents all the melanoma patients that had responded. And you can see in the column on the right, this time on study. That means patients that did respond but remained in response. And there was a little plus after every single person there. And I remember Dr. Schnoll getting up there on the podium at ASCO. The room was almost empty, but there were a few crazy people sitting and listening to him talking about this drug targeting a molecule that no one had heard of. And he said, in all the years I've been doing oncology, I haven't seen a table that looked like this ever before, something along those lines, right? With every person who had responded remaining in response, because the chemotherapy that we used to give did make tumors shrink. It just didn't last very long. So we knew at that point that this was a drug that was really going to induce prolonged responses in approximately 30% of the patients in this particular trial, maybe a little bit better than that. So what do oncologists do when they've got one drug that was the Yervoy that works in around 20% of patients and works for a long time, and the other one is this nivolumab or Opdivo that works in a higher percentage of patients? What do? We mix them together. We actually didn't even have any preclinical data or any data other than a single mouse model for colon cancer, of all things not melanoma, at the time, that just really demonstrated well that the two drugs were synergistic. In other words, that they would add something to each other than the theoretical rationale that we're targeting two different checkpoints within the immune activation system. So this is the phase 1 trial that was conducted over here at Sloan Kettering. And again, I think there's some participants from that trial sitting in the audience here. So people who received these two drugs together, starting at lower doses, and the doses were then extended. So this plot over here is called a swim plot. And on the x-axis down here, you have months. So you can see people were treated. The red is people who came off therapy most of the time because they had one or other side effect, but they responded and remained in response. And you can see these little arrows over here to the right indicating that these responses were ongoing. So if any of you wonder why our clinics are busy if you come in on certain days of the week, the one reason is that there are a lot of people who've had metastatic melanoma, received these therapies, come off therapy because of side effects or because they just had enough, and come in to visit and make our clinic a wonderful social place to be in. This is the survival curve from that particular trial published fairly recently, and you can see that at 3 years, over half the patients were alive and doing well. After that, there was a very large phase 3 study conducted where patients received either two drugs alone or either one of the two drugs by themselves. And just to cut a long story short, The two drugs together did much better than either drug alone. You can see the numbers over here circled in red. 57% of the patients who got both drugs, 43% of the patients who got Opdivo did well, and the Yervoy 19%. So this led to the approval of this regimen by the FDA. Now, we talked about targeted therapies as well. There are 50% of the patients who have this mutation in the gene called BRAF. There are now a series of drugs that target BRAF. And we target BRAF and MEK at the same time because it works much better than if we target BRAF alone. And this is another alternative approach that we can use for patients who have BRAF mutations in their tumor and are either not responding to immune therapy or not tolerating the immune therapy. So it gives us a few other options. This over here is called a waterfall plot. Anything below the x-axis, and actually the colors don't project very well, but anything below the x-axis shows tumor shrinkage. So these drugs work really, really well in the patients who have the BRAF mutations in their tumors. So we're in a much better place than we were in 2004. We have a bunch of new challenges now, and we really welcome your partnership over the coming years to try to overcome these challenges. So the first one is that not all patients respond to the immune therapies. What about the 40, 50% or so that don't? We need newer regimens for overcoming resistance to these newer therapies. These drugs are incredibly expensive, so we have to try to identify who's going to do well with one drug, for example, and doesn't actually need two drugs. And maybe we can reduce the costs that way. There are lots of studies ongoing at Yale right now looking at that. Patients who have autoimmune diseases like ulcerative colitis, rheumatoid arthritis, those kinds of diseases have a harder time with these drugs. We need to have alternative methods for treating those folks, as well as patients who get side effects from the drugs and really can't tolerate them. Patients who don't have that mutation in BRAF, if they don't respond to the immune therapy or don't tolerate immune therapy, we really have a lot of work to do there to try to find other targets within the cancer cell that we can drug. Melanoma from the eye or uveal melanoma remains a real challenge for us. It's more difficult to treat. And patients who have brain metastases have a whole other unique set of challenges that I could spend an hour talking on, but I won't because I think everybody wants to break for dinner. Just to touch briefly on these topics that we are doing research on at Yale, I think we have this big grant mechanism that Dr. Schnell is going to talk about that touches on many of these different areas. We need to have newer approaches for the patients who do not respond to the currently approved immune therapies. We're dealing with how to decrease the incidence of and the severity of the autoimmune side effects, identify patients who might respond to less aggressive regimen and the like. So we do see when we give that dual therapy regimen, at least 50% or so of patients have significant side effects. And that is a bit of a challenge. I'm going to show you just in the next minute or two what we're doing for brain metastases. We have a clinical trial, which we think is very promising. Patients are getting the one PD-1 inhibitor called Keytruda or pembrolizumab, along with a medication that helps with all of the swelling and modulates the vasculature around the immune cell. So this is an example of an MRI of the brain of a young patient that we treated over 3 years ago. She had a lot of tumor actually in the brain. This was her brain MRI a few months later, and she continues to be in complete response and off therapy. This is another gentleman who we treated with about 100 small brain metastases. This is his brain MRI afterwards, looks beautiful, and he's still doing well and off therapy at this point. So Dr. Schnell will be expanding a little bit more on the clinical research that we're doing. Our areas of focus are the resistance to PD-1 inhibitors, understanding and mitigating the side effects of the immune therapy. We've got newer approaches where we manipulate and modify the cells that live within the tumor. We take them out and can then reinfuse them after manipulation. And then, of course, personalizing these approaches so that it's not a one-size-fits-all. So I just want to end by acknowledging everybody in this room. We have a clinical research team all sitting in the third row from the front over there. We thank you all. Annette is sitting closer to the back. We couldn't do any of this work without you. We have our clinical team. I see Laura even came back from maternity leave to be with us. But we have a large team of wonderful people who are really helpful with taking care of patients, moving the research forward, and really embracing all of the challenges that we face sometimes in the clinic with the toxicities. We've got our pharmaceutical collaborators, our laboratory collaborators, and of course, more than anything, patients and families. So I'd like to thank you for your attention. I think we're going to do a question and answer session right now. So I don't know if anybody has little cards that, or if anyone was collecting them.